Hi, my name is Nathan Shippey. I'm faculty in the Division of Health Policy and Management at the University of Minnesota and with ResDAC. ResDAC is a CMS contractor. We assist with understanding Medicare and Medicaid programs and accessing and using CMS-related data products, generating cost estimates and invoices for CMS data, and preparing requests for CMS data. First, I want to acknowledge various assistants, especially from Senior Fellow Sarah Durham. We'll first be covering some reminders regarding CMS and administrative claims data, including caveats and limitations. Next, we'll cover some examples or pictures of how we might use Medicare data, including reminders and caveats as we go along. And finally, we'll cover briefly how and where to get data and to get help with the data. To begin with, some reminders. CMS is itself a payer in the healthcare game in that its primary job is healthcare insurance coverage. It's an insurance company that generally wants people to use its data. But that means we're dealing with administrative claims data, which, as always, are not gathered for research purposes. Now remember that while we're discussing Medicare data, there are of course other claims, survey, and assessment data products available through ResDAC. Medicare data are comprised of multiple files split into categories or settings of services such as hospital inpatient file, outpatient file, the carrier file with physician and other supplier claims, and so on. The files don't all have the same structure to them, so there is a learning curve. However, the size, research friendliness, and granularity of files does differ. Some files may be more user-friendly or smaller, requiring less computer storage and processing power, which can be significant hurdles, or which have fewer data restrictions in terms of confidentiality and data storage. These benefits are good, but they may have to be balanced against potential decreases in granularity, though the trade-off depends on the variables you're interested in and may not be an issue, so it's important to check and ask ahead of time. Next, as someone who grew up as a stoic, pragmatic, rural Midwesterner, I tend to focus on caveats and cautions, but I don't want anyone to take these too negatively. Regarding administrative claims data, some limitations or considerations include: first, the fact that we often have to rely on 100% fee-for-service enrollees to ensure our samples have complete claims. Thus, we lose managed care and may be dealing with an unrepresentative population depending on the question. Also, we rely on claims for services, which creates a few issues. That means that we use service claims as a proxy for a patient's conditions. But of course, an ICD-9 code doesn't always mean a condition is truly present. For example, diagnostic testing may signal an ICD-9 code but be negative, so we need to consider that in our algorithms. Conversely, lack of services for a condition does not mean the condition is not present. And in some cases, lacking a claim doesn't mean a service didn't happen. Moreover, this measurement error and potential bias depends on the condition or treatment you're talking about. For example, obesity would be likely undercounted and untrustworthy in claims data, but the presence of very high BMI is required for Medicare coverage of bariatric surgeries, creating an impetus to code for it, making it near universal in those receiving such procedures. Next, in claims data, we are of course missing pieces of the overall puzzle of health and healthcare, and we also need to be cautious in using claims to address certain questions like quality of care. Finally, the context and history of the data can be important. Variables become available or drop out, which makes documentation such as data dictionaries really important and limits some trend analyses. Additionally, because we're talking about claims in fee-for-service, the potential for issues with upcoding or other responses to changes in reimbursement should be taken into account. And last but not least, some very related issues regarding emergency medicine and files generally. First, most information on ED visits resulting in an inpatient stay can be found in the inpatient data. The degree to which this is the case is still a bit of a question that we're looking at. Second, in many cases, care delivered in the emergency department, but found in the inpatient data, may not be separable from care delivered in the hospital, unless those ED services have dedicated codes identifying them as such. In fact, depending on the file, inpatient data may be one line per stay rather than one line per claim. Third, and also related, if you find visits in the outpatient data, they cannot just be assumed to be true outpatient ED visits. There are specific reasons why certain components might be billed separately in the outpatient, inpatient, and other files. So you still need to look at both IP and OP, that is, inpatient and outpatient files. Just a note here, there are different privacy levels for CMS files. I'm not going to read them all, but note that the more identifiable files tend to be more restricted. Please see other ResDAC resources for further details if you're not familiar with these at resdac.org. Very basically, you should plan on using the minimum privacy level, only the necessary files, and the minimum analytic cohort to answer your questions. And your data request or any application materials should reflect this. The upside is that many variables of interest to researchers are available down to the limited dataset level, which is not the most restricted. Although public use files or PUF files tend to be limited in scope and are not useful for certain questions. However, there are some differences from the RIF, that is research identifiable files, to the limited dataset versions of files, so be sure to check. Next, we'll look at a few pictures of emergency department use in Medicare. We'll be using data from the 5% random sample, which allows for quicker computation time, and 4 files from 2012. The Master Beneficiary Summary file, which contains information on enrollee demographics and other information, and the standard analytic files for inpatient, outpatient hospital, and carrier claims. We used the research identifiable file versions, that is the most restricted versions, but you could do all of this and more with the limited dataset files, the less restricted versions, if you keep it to 2010 forward. That's because earlier years didn't include dates in the limited dataset files. As we go through these, keep 2 things in mind. First, the caveats and reminders, and second, that these are mainly for examples, so please don't overinterpret what we're looking at. Here's a simple demographic look. The left side columns are proportions of visits, whereas the right side are proportions of fee-for-service enrollees in this 5% sample. Thus, the totals at the bottom show us that there were about 860,000 emergency department visits among this 5% sample of 1.55 million fee-for-service enrollees. Extrapolating to the total fee-for-service population would indicate roughly 17 million emergency department visits for 31 million enrollees. Those who are older, male, and who have dual status with Medicaid are overrepresented in their proportions of visits to the emergency department. For example, duals make up 15% of fee-for-service enrollees, but account for 27% of visits. You can get similar breakdowns by rural, urban, and of course by race, ethnicity, or look at disabled or end-stage renal disease eligible beneficiaries, that is those under 65, and several other variables. You can also look at counts of emergency department visits per beneficiary, costs, and so on by these groupings. This table used the Master Beneficiary Summary file, the Hospital Inpatient file, and the Hospital Outpatient file. Using just the inpatient file would miss, for instance, visits that did not result in an inpatient stay. How did I get here? That is, how did I get to the emergency department? We can review ambulance use from the same day. If we're going down this road, to obtain information on services in an ambulance, we actually have to rely on 2 files due to ambulance ownership. If it's an independent supplier, it would be found in the carrier file, which covers physician and supplier claims. If it's a hospital-owned provider, then it would be found in the hospital outpatient file. A complete picture of ambulance use would require both. To find these services, we need to look at Level 2 HCPCS codes. If you're unfamiliar with the larger Healthcare Common Procedure Coding system, there are two levels. Level 1 is comprised of CPT codes. Level 2 is comprised of some of these other non-CPT code categories, such as ambulance services. We've used these codes at the Level 2 to get some ambulance use numbers. Out of all visits, we identified 39% with some ambulance claim. Based on the file types above, we found most in the carrier, not the hospital outpatient file. The oldest beneficiaries and females accounted for the highest numbers of visits. There's lots of other information in the ambulance claims, so it's an area ripe for study. Here we've grouped some ICD-9 diagnosis codes associated with emergency department visits, overall and across sex and age categories. I've highlighted the groups for whom the selected categories comprise a greater proportion of ED visits. For example, fractures, including skull, trunk, spine, or limb fractures, are higher for women and the oldest beneficiaries. Also, 13% of emergency department visits by beneficiaries included a mental illness diagnosis, though this differed greatly by sex. I included a number of conditions in that category, but you could certainly break it down into schizophrenic disorders, bipolar disorders, or other specific disorders. One note, these are not mutually exclusive categories. A fracture and a spinal cord injury for the same visit would be counted in both categories, though you could do it differently. And now for E-codes, for more information on the nature or cause of injuries. Here we've taken the top 3 E-codes for each of a number of injury categories in the ICD-9 injury codes. As you'll see, we get a pretty homogeneous set, at least doing it this way. 30 to 50% of all visits with diagnoses in each of these categories are taken up by just 2 E-codes. That is 885.9 and 888.9 in the blue and orange, which are accidental fall from slipping, tripping, or stumbling, not otherwise specified, and other fall, not otherwise specified, respectively, if you can't read them. Obviously, a fall with associated pelvic or hip fracture, the second or third rows respectively, would be likely to show up as an NOS fall E-code. So remembering the population, that is older adults, is key here. I also think this is interesting because the domination of these codes is true even of the open wounds injury codes. The number 3 codes are a bit more heterogeneous. Note that the percent with no E-code does range from 8 up to 16% depending on category. And of course, if you were looking for a particular E-code rather than the top 3 as we've done, you could certainly find it. Now, some context is sorely needed in relation to E-codes. The 10th diagnosis variable in the research data, while present, was empty until 2009. In 2009, the 10th diagnosis variable began to be populated and more E-codes were available. Prior to that, a very small percent had E-codes in the other diagnosis variable slots. Finally, a new E-code variable became available in 2010. Other work by Sarah Durham, the fellow who produced these numbers, shows that there was a big jump in overall E-code availability in the data from 2008 to 2009, and then again from 2009 to 2010 when the E-code variable was introduced. Some E-codes do still show up in regular diagnosis variables. It's a near negligible amount, but you may want to pay attention to both to get a full count. Thus, a set of corollary caveats then are the following. Prior to 2011, the coverage of E-code variable versus other diagnosis code variables in capturing all E-codes is suboptimal. Next, prior to 2010, the percent of injury stays with an E-code was pretty low, and even lower in 2009 and before. Relatedly, comparing across years, prior to roughly 2011, is fraught with the possibility of data artifacts biasing your results. Other considerations for conditions include various algorithms and approaches to avoidable or potentially preventable visits to the emergency department, which may or may not be similar to avoidable hospitalizations depending on the algorithm, and V codes. The only thing I would say about V codes is that we would need to consider whether a given V code of interest in showing supplementary information would be reliably entered for all people. If that assumption is reasonable, then we're fine. If not, as with other coding patterns in claims, we need to be cautious. In terms of what beneficiaries receive, we of course can start with emergency department related E&M codes. Those are evaluation and management codes. Remember that E&M codes are current procedural terminology, or CPT codes. Those are level 1 HCPCS codes, and so are of use mainly for outpatient claims. This is a bit of a rough look since it's only from the outpatient claims, though of course that doesn't mean people weren't admitted. Remember the caveats. It also is run on the full outpatient file, meaning that the typical restrictions we talked about before, that is 100% fee-for-service only or only 65 plus, are not held here. So again, this is just for example. But if people are interested in studying trends in the use of more highly reimbursed codes across time, those are the higher numbered codes, this table shows some potential evidence of that. This isn't risk adjusted for, say, increasing severity or acuity, so one can't draw much conclusion from this table alone. But you can build such adjusted numbers if you're interested. And of course, you can obtain financial amounts as well. A separate analysis we ran on the same data showed that facility reimbursements for the 99285 code were on the rise as well. Again, these are unrefined data runs, but they show what kinds of questions we can ask. Beyond E&M codes, of course, there are other CPT codes, again, the level 1 HCPCS codes, typically for outpatient services. And beyond that, since CPT codes are not used for billing in the inpatient settings, but ICD-9 procedure codes are, we can also look to the ICD-9 CM procedure codes for diagnostic, surgical, and other services which are in the inpatient setting. And last, we can think about what happens after the emergency department visit. Here we used dates of inpatient codes and emergency department visits, provider numbers, and discharge status codes to get admitted at the same hospital, transferred, meaning admitted by a hospital with a different provider number than the ED, and died. For example, nearly 40% of patients are admitted at the same or another hospital, but it's only about a 33% of those aged 65 to 74. A small percentage of these Medicare fee-for-service enrollees die in the emergency department itself. I should note that doing the analyses for admitted and transferred this way may count some true transfers as same location admissions. Beyond that, of course, we can look at ambulatory or acute utilization, procedures, incident diagnoses, or health events after the visit as well. On to accessing data. I'm presenting this slide here to lay out the basic process of obtaining different kinds of data files. I won't read each process, but note that there is much more information, training materials, and assistance at resdac.org, and that the process for accessing data does vary by file privacy level. Also, note that CMS also has a Virtual Research Data Center, or the VRDC, at which you can pay an annual fee for a user seat to obtain access to most RIF files. If you're doing a lot of analyses with a lot of files, this may be a very cost-effective option for you. So see resdac.org for details. If you want to contact me, I've listed my email and Twitter handle. And finally, if you have any questions regarding this presentation or CMS data in general, or wish to obtain data, please contact ResDAC using the phone, email, or web address listed here. If you remember nothing else, remember our website, resdac.org. Thank you.